but I will use the original Norwegian presentation. So you will see the text of my slides in Norwegian, which is not so different from Danish. I have a Danish friend who said that Norwegian is like Danish with spelling errors. So maybe that is true, but I will try to speak slowly and understandable in English, and I'm very happy to be invited to present. Then I start my slide. Nicoline, is everything okay with the slide? Can everyone see it?
Yeah, we can see the first slide, the introduction.
Good. Røysumtunet was established as a cooperation between the Norwegian ME Association and the deaconal institution Røysumtunet. ME Association searched for a place where they could find a safe haven for the very sick ME patients and establish institution where they were treated according to the NICE guidelines and with dignity and love and care. And that is what we have been trying to establish at Røysumtunet, a unique institution, both because it's the first in Europe and because it is a cooperation between the ME Association and the institution, deaconal institution of Røysumtunet. As we have seen the model evolving, ME Association is more like a supporting partner. They are not so involved in the day-to-day treatment and follow-up of the patients, but they are like a resource and a good partner that we can lean on when we need it. So that's a good model for us at the moment. It is difficult to evaluate the results because it is very individual and it's subjective to errors. And we are trying to present some results in peer-reviewed journal, but so far we have not achieved that. We have also not an updated status for the institution. The results I present here are more than a year old, but it reflects the situation. And so far, about 1 year ago, I presented this slide at the conference at Farris Bad in Vestfold in Norway. And we found that out of the patients we had been treating so far, 10 had received full treatment. And out of those, 8 had a good response and 2 partially good response. 2 received treatment that was not complete, and out of those, 1 was partially improved and 1 was unchanged. And for several reasons, 3 didn't receive any treatment, and they were all unchanged. It is very important to emphasize that everything is voluntarily. People come to Røysumtunet with their own agenda for what they really want to happen there. Some want only good nursing care, love and tender care, and we try to give that. And some have their own beliefs about treatment, and that is why some don't agree to all the ingredients of our treatment, and some try them and they have side effects, and they don't want to continue. So that's why we have this situation where not everyone receives the full treatment. But we have two distinct goals with our institution. That is to give good care, and that is to give medical treatment. So this is the situation. If you look at the situation at the ME field, there is no treatment protocols that are acknowledged by the Norwegian health authorities. And that is the situation in most countries. But it has been done a lot of research, and by searching international databases, we have found a lot of good studies indicating that different substances can have a good effect on ME. And I searched out a protocol which was also approved by my the other doctor, Ola Didrik Saugstad, who is a professor emeritus from University of Oslo in pediatric medicine, and also have engaged very much into ME research and follow-up of ME patients. The situation is that only in a few cases there are large randomized double-blinded studies, but those studies who are available are sometimes very promising. And the reason why there haven't been done these large studies is because it's very costly. And as you all know, the ME field is like a stepchild in the medical world, where it's not a place where there's a lot of money for the big pharmaceutical companies, and it's also neglected by the authorities in many countries. So the huge amount of money that is needed for large randomized studies are not there. So we have to rely on studies that are limited sometimes, but then we also have the choice between not giving any treatment at all, or wait for these studies who maybe will never come. And my choice has been to try out and to harvest the personal experience with a bunch of vitamins, minerals, and low doses of medicaments. And they are all have in common that they are low toxic and low dosed substances that has good documented security and few side effects. Before starting, I sent to the health authorities the outline of a protocol, and they neither said yes or no. They just said, we will see. And as I didn't say no, I chose to start and try out this protocol. And it is not a formal research, nor it is a clinical trials, because that is very strict how that is done. And we cannot, we don't have the resources to do that, and we don't intend to do that. But we are trying to find a strategy for medicamental treatment of a serious disease where the patients very often are sick year after year without any improvement, even with maximal avoidance of PEM. So that is the situation. And now I will outline for you some strategies with the steps. Every patient is like a guinea pig. That means that they have to try out, because we see it's very individual how they respond to the treatment. So we can never predict whether a patient is going to improve or not. So the first step is introduced for 2 months, and then we evaluate after 2 months. And if it is effective, we keep the substances of the first step and add the substances of the next step. If it is not effective, we of course stop it, and then we substitute it with the next step. So you can end up having all 4 steps all together at the same time, and then we often see a nice synergy effect, or you can end up with no one. Our experience is that most of the patients have a positive effect of between 2 to 4 out of these steps, and that is very promising. I will first present the first step. That is high dose thiamine or thiamine, vitamin B1. We don't have time to discuss the background for this, how it works, but basically it is restoring the methylation balance of the body. You can find a lot of background in other sources. So that is, we will just briefly go through. The main study we built on is a study performed by Palle Baga in Denmark. He was studying the severely ill patients with irritated bowel disease, which also has severe fatigue, and obviously also fulfills the criteria for ME. So they also were ME patients. And he found a very high response. I think it was around 75% of the patients who responded positively, and they even had got worse on placebo. That was a double-blinded study, actually. So that is one of the best studies we have. We are building on. And there's also an old study by Constantini who found the same. The side effects are mild and not lasting, and the security is vital to us, that we don't introduce anything that is dangerous or can harm the patients. And all vitamin B substances are water soluble, and they are excreted into the urine, so you cannot get intoxicated by these substances. The dosage is between 600 and 800 milligrams. And we also have a lot of supportive substances like N-acetylcysteine, different vitamins and minerals. I don't have time to go through that. But that's step 1, the first part. And we also add in step 1 oral rehydration salt, which increases the blood volume and the brain perfusion of blood. That builds on a study from New York by Meadow from Children's Hospital, where he found through different investigation that there is a low blood volume and low perfusion through the brain of blood. And he found a very distinct improvement, also compared to intravenously administered saline. He found that there was a very distinct improvement of both brain function, but especially on POTS, postural tachycardia syndrome, which many patients has. The problems we have seen with it at Røysumtunet is that it is people react on the taste. It's difficult to drink, and fortunately we don't have any heart diseased patients. But if you have a heart disease, you have to be careful with these volumes and all this salt. The patients are drinking 1 liter of the solution within 1 hour to get this boosting effect. And the next step is 2 antioxidants, NADH and Q10, and intra and subcutaneous injections of B12 or hydroxycobalamin. First study was done by Castro Marrero and his group in Spain, combining these 2 antioxidants. Many people use other antioxidants, but this study was double-blinded and very convincing. They found better cognition, sleep, and a higher energy level in the patient group compared to the control group. And they checked for effects on liver and kidneys and didn't find that. The only thing you have to be careful with is that Q10 cannot be combined with warfarin. This is used for anticoagulation. The dosage are 200 milligram of Q10 and 20 milligram of NADH. The next step is B12, hydroxycobalamin injections. And what B12 does is that it is a coenzyme for a lot of metabolic pathways in the body. For example, the conversion of homocysteine to methionine. And the basic study we build on was done by Björn Regland at the Gottfried's Clinic in Sweden. And he found effect on cognition, energy, and pain. It was long. Some people who said that it could, high doses of B12 could lead to different kind of cancers. But WHO went through all the literature and the studies available and said that no, there is no such association. So from that point of view, it is safe. It's also important to know that people who are on SSRIs, antidepressiva, and different kind of opiates, they will have a reduced effect while on high dose B12. So either they have to find other painkillers or other drugs, or they have to increase the dosage. What we are doing is giving 12 milligrams into 10 milligrams subcutaneously twice a week. Before, it was always thought that you had to give B12 in intramuscularly, but Regland found that it was just as effective to give it subcutaneously, and that means that the patients or some of their loved ones can inject the drug themselves, and it's just like a patient with diabetes who injects their insulin. It's very easy. And what Regland found that it was the higher the frequency and the higher the dosage, the more the effect they found. So, and we have been contacting Ola Didrik Saugstad, have some contacts in the United States who are work very careful with this long time, lot of experience, and they recommended that we increase the dose from 5 milligram to 10 milligram. So we have followed their advices. 5 milligram was the doses of Regland. The next step is low dose naltrexone, which is where we build on several studies. but the main study was done by Polo and his group in Finland. There's a lot of Nordic research here, as you see. What LDN or low dose naltrexone does is that this increases it blocks the opiate receptors in the brain partially, and those increases the body's own production of endorphins, which is leading both to a pain-killing effect, and it modulates the immune system, which means that it is decreasing the inflammation in the body. It works on cognition, it works on energy, it works on pains. The main problem with naltrexone is that it is a lot of patients have very vivid dreams, nightmares, so to say, and some patients experience that they get worse before they get better. And it's a very slow drug that the effect comes very often starts after 2 months and can come as late as after 6 months. So we have to be patient with LDN, but the effect is very stunning when it comes for a lot of patients. So it's a very good drug. When you treat, it was originally developed to treat opiate dependency, and then you use 50 milligrams. And you see here we use less than or about 1/10 or 10% of the dose that is considered safe. Even 50 milligram is considered a safe dose. So this is not a big risk for the patient. And we start very, very low. We start often for those who are very sensitive. ME patients are very sensitive to drugs, generally speaking. So we often dissolve the tablets in water, and then you can apply it as drops and slowly increase the amount. So you will not have all these side effects. The next step is and last step is Abilify or aripiprazole. That comes from a very clear research result that there are inflammation in the brain. That was first found by a Japanese group through a PET scan, special PET scan of the brain, and has been confirmed by several studies later. And knowing that the brain fogs come from an actual inflammation, Crosby, actually it was Ron Davis who tried it on his son, and the group at Stanford University. Knowing that aripiprazole usually inhibits the dopamine activity in the brain, and that is known to have a inflammation reducing effect, then they tried it out on ME patients, but in a very, very low dose. Aripiprazole has a lot of side effects, and it's in high doses used to treat psychosis, bipolars, and other. It's very effective psychoactive drug, but it has a lot of side effects. In these low, usually when you treat an acute psychosis, you use 20, 30, 40 milligram, but Crosby used very, very low doses. But it was not a very, it is what you can say is a pilot study, only on slightly more than 100 patients. But they found a very distinct effect, even in these low doses, on the brain fog, which is a very prominent symptom of ME, and also effect on the general energy level and other things. It is the drug that has most side effects, even in this, among all the 4 steps. That's why we introduce it as the 4th step. You can have the most prominent we have seen is headache, but also sleeplessness and agitation. And a lot of patients have, and not a lot, but some patients have to stop it. But it's tolerated. If you can survive the first 2-3 weeks, usually these side effects are decreasing and it is tolerable. It has also been uttered that it could lead to increased weight, but it has been found that when Crosby went through the material, they didn't find that the patients on aripiprazole had more weight gain than other ME patients, because weight gain is the feature of ME patients in general. And we start with a mixture or drops, 0.25 milligram. We increase by 2 drops a week until we reach that is 5 drops, and until we reach 1 milligram, and then we switch to a quarter of a 5 milligram tablet. Go on with 2 weeks on that, and then finally half a tablet, which is 2 milligram, 2.5 milligram. That is a maximum dose we give, and most patients end up with either a quarter or a half tablet, depending on how they tolerate it. But this is our 4 steps treatment protocol, and I think I have reached my time. But I have to say that nothing is hooked i stein. No, nothing is. These are debatable, and we also see already now that when we develop the new Nordic protocol, we are introducing other substances, and we are also changing the order which we introduce these different drugs. Yes.
Thank you. Thank you, Dag. Very interesting. And a lot of questions has come in during your talk here. So I'll start reading them out to you, and you can answer them in that direction before we have a break of 20 minutes. So to go right through it, the first question is about your slide with oral rehydration salts. You mentioned in your slide that you use 3 packs of GEM in 1 liter of water. What is GEM?
That is the oral rehydration salt. It's a Norwegian brand. You can find it on everywhere. You can also go to the web pages of UNICEF, and then there they have a recipe on how you can make it at home.
Okay, so it's a kind of salt water.
Yes. That is. I used to work as a doctor in Bangladesh for some years, and that is the origin of ORS. ORS has saved millions of children's lives all over the world. It's used with dehydration when you and it can be made at home very easily.
Okay, thank you. And the next question is, do you test for various deficiencies of vitamins and minerals, etc., to individualize for optimal treatment?
Yes, it depends on if the patient has been properly investigated before they arrive at the institution. But there is a program that we take through, which tests for vitamin D. We test for vitamin for folate and for B12. That are the 3 ones. But we are also testing for other B vitamins. But it's not. The big thing is actually that even if you test for these vitamins, you will find that they have normal levels. But the problem, for example, with B12 hydroxycobalamin is that the mechanisms the channels and the proteins that is supposed to transport B12 into the cells are defective in ME. So we can say that there can be a lot of B12 in the blood or in the extracellular volume, but there is a deficiency intracellularly, and that is when you increase the amount of B12 so high that it diffuses into the cell through osmolar mechanisms.
Yeah. Next question. Can the severely affected ME patients have a malabsorption of various nutrients, and they therefore need to have these supplied intravenous, for example, food or intramuscular injections every day in high doses of nutrients, still doesn't give the wanted effect?
Yeah, well, we have nutritionists that have worked with ME for 20 years, which is also connected to the National Competence Center for ME, and she's very skilled. And if we see signs of nutritional problems, we work very close with her. And we see some patients have a nasogastric tube and get all their feed. They cannot even eat. They are too weak to eat, actually. And some even receive intravenous nutrition. And there's a lot of challenges with nutrition with the severely ill ME patients. And I cannot go further into that here because it's very individual. But we are very alert to give our patients a good nutrition and to give them the right nutrition. And we can check for all these vitamins and minerals, and we do that regularly. But it's individualized. And also in my practice, as I have my own ME clinic here in Lommedalen, where I see many patients, and I also give them advices on nutrition. It's very important to, generally said, it's important for ME patients to have enough and varied nutrition so that they don't wean, that their weight is not decreasing. And it's important also if somebody has a problem with too much weight, and then we advise them on that. And but it's individualized.
Yes, of course. Thank you. There's a lot of questions here on especially malnutrition and etc. But one question is, have the ME patients at Røysumtunet been deficient in carnitine, and have they been able to benefit from fat ketosis autophagy?
Yeah, that is interesting. We are introducing nowadays a step. We have 6 steps at the moment, but I cannot tell everything about it because it's takes too much time. We are, as I said, it's not carved in stone. We are changing things all the time. And one of the steps that we have recently been introducing is a step that consists of carnitine and L-carnitine and D-ribosis. And that's very promising. That's built on several studies that carnitine is crucial to ME patients, that they get enough carnitine. So we are introducing carnitine as a part of our treatment program. Okay,
interesting. Have you had severely affected ME patients who have had rare complications with the B12 injection shots?
We have never seen any severe complications. and that's because B12 is very harmless to the body, generally speaking. Of course, somebody can have rare reactions, but we haven't seen it so far. But one of the experiences by Regland's study at Gottfried-klinikken was that they compared the B12 administered orally as tablets to the injections, and they found a very striking difference. And we found the same before. We were a little bit reluctant in the beginning to introduce injections, and we tried out high doses of tablets and saw very little effect. The real effect came when we introduced injections. Regland experienced the same. I have not a good explanation, but that is how it is.
Okay. Another question here is, can zinc and phosphate also be treatment refractory in magnesium deficiency, just as it is with, for example, calcium, potassium, and possibly sodium?
Yeah, we check all the patients for phosphate and magnesium. And as a part of step 1 is kalium and or potassium and magnesium. So we give all the patients as a part of our basic treatment. We give magnesium and kalium along with thiamine.
Okay. Thank you. The other questions, I think you already covered many on magnesium. So thank you, Dag. We'll take a short break now on 20 minutes. That means we'll be back at 12 o'clock.
Yeah, 12 o'clock. That's good.
Yes. Thank you. And remember, you can still ask all your questions in trekant, firkant, bolle panelet forneden. And remember to press anonymous when you do. See you at 12 o'clock. I can see a lot of question has come in during the break, but we'll just answer all those when you're finished. Or do you want to take them now, Dag?
You can decide that. It's up to you.
So maybe we should take them now when we start in 1 minute, and so it's kind of related to what you have just been covering. And we'll come back to the rest of you. So we'll just go through the remaining questions you put during the break. The first one wants to ask how do you become a patient at the Røysumtunet?
Yes, and that is the kommune or the municipality where you are living has to pay for your stay. And that is actually at the moment a main obstacle for our survival, actually. It's a very painful question because a lot of we have estimated there are between 200 and 300 severely ill, very severely ill ME patients in Norway, which are actually in a desperate situation with the need for our care and our treatment system. But they are not able to come to Røysumtunet because their local municipality is not willing to pay for it. So that is one of the big question at the moment. Will we survive in the long run? Because at the moment we have 12 the capacity for 12 patients, but at the moment we have only 7 patients because it is we had to close one of our 3 houses, and we are running with budget deficit because and we don't know. We are a little bit we're not sure about the future because of that. Actually, it should be a national system for these severely ill patients, but the politicians are not willing to look into it and provide for that. So,
and it's not possible to pay as a private person?
Yes, it is, but it's very costly, and it is of course, these patients, many of them demand one-to-one care, that the one caretaker has to dedicate all their time to only one patient. And of course, that is very expensive.
Mm-hmm.
And we feel it is almost ethically not recommendable to ask so much money from the family or the patient. So it's very difficult, actually.
Yeah, and you don't take patients from outside Norway?
At the moment, we are not.
No.
But we are open to discuss it. But it's this is the most painful question at the moment.
I understand. It's really, we see that right now in Denmark we don't have a place like that, and it's the family themselves who pays with their time and their money to take care of their son or daughter, or like you do there. Are there the next question is on this topic also. Are there other places like yours in Europe? But I guess there ain't.
No, we are as far as we know, there are no other dedicated ME institutions for the care of the severely ill.
Okay. And are most ME patients affected by, this is a medical question, affected by metabolic syndrome, like insulin resistant?
No, that's not a part of the core clinical picture. No. But you can see that if you have the diabetes type 2 is a complicated disease because it has a genetic vulnerability, and it has to do with diet and lifestyle. So if you're very inactive and your weight is increasing, then a lot of people develop diabetes type 2 or metabolic syndrome, and some ME patients as well. We are aware of that, but most of our patients are young, so they haven't come to that.
Okay. This is another question about hypersensitivity. Hypersensitivity in eyes, ears, skin, or in digestion. Can you treat that? And has Abilify and Aura CA an effect on this?
We are very aware of hypersensitivity. That's why we see that, for example, against drugs like Abilify or naltrexone. So we have to be very careful and increase very, very slowly, and observe carefully how the patients are reacting. It's in my practice also, I see that ME patients react very different from other patients regarding all kind of drugs, and that's a part of the ME syndrome, actually, and that's why you have to have a lot of knowledge about ME to treat these patients. They are very special group of patients also regarding to hypersensitivity. When that is said, we use alimemazine very often as have the patients sleep. So most of the patients are on antihistamines to treat their sleep disorders. And one of the effects of that is that we also reduce the hypersensitivity.
Great. One wants to know here about, do some severe ME patients get total parenteral nutrition, TPN, for the rest of their life?
No, not for the rest of their lives. We haven't seen that, but for example, one of the patients we had has been had for a time a combination of parenteral nutrition through a Hickman catheter, and then at the same time a PEG sonde, and has been gradually decreasing over a long time, the administration through the Hickman, and are now solely on PEG. So we try to enhance that. They leave the parenteral nutrition as when it's possible, but we always respect the patient's personal wish and preferences. We just give them our advices, and but it's not very healthy to use parenteral treatment in the long run, because you get a lot of it's very difficult to give them all the trace elements and vitamins and all these things that you get through an ordinary diet.
Yeah. This is another question on you and your consultation. Is it possible to book a consultation at your clinic? If so, how? Because the website Røysumet.no does not provide mail or phone number.
No, actually, it's very sad, but there are very few patient specialists in ME in Norway at the moment, and I have been so overwhelmed by patients that are often very desperate to get treatment and follow up, that I had to limit it, all the questions, and that's why I don't provide that. But the system in Norway is that what I encourage people is that they send me that their general practitioner, they send me a note that they want the patients to be seen by me. So everything goes through the GP.
Yeah.
But I don't have the capacity to take patients from other countries at the moment. I'm very often droning in patients, even in Norway, so I have to be selective. And I sometimes, when I see that the patients are not typically ME, I had to say that you should search that expert and this expert first. And I have to sort, and I cannot see all the patients who wants to come to me.
No, I understand. The Norwegians are very, ME patients are very lucky they have you. So hopefully this new Nordic protocol would help on some level. There's a question for that here now. Somebody asked, the new Nordic protocol you mentioned, with new supplements and medicaments, can you give examples on the most promising supplements and medicaments in this new protocol?
If we have time, I am going to present a little bit from that protocol now. So it depends on how long we can go on. So
okay, fine. And last question, I think there was one last question here. Yeah. It seems like patients need a list of which medications that you recommend here that GP can write out for them, and under which indication. Because this is not what Danish GPs normally write out for sleep deficiency and stomach problems.
That is a big problem because there are no, for example, in Norway we have a system that necessary medicines are covered by the healthcare system, but there is no medicines that for ME patients that are covered by the health system. It's very unfair that if you have a heart disease, everything is covered for you. If you have ME, nothing is covered for you. So if you follow the protocol here, it usually costs the patients 3,000 to 4,000 kroner per month, and I really feel it because it's many of them have a difficult economy, and we are recommending drugs that they have to pay in full for themselves. Even we faced a lot of doctors are skeptical, but I have a document that I can provide to the ME Association of Denmark that you can give to patients if you want, where we argue for our model for treatment and also the mechanisms of ME and the dosages and everything. So that's the best I can give so far. The Scandinavian protocol, we are going to discuss it a little bit, I hope, in Stockholm in next month, and can maybe land. It was put on pause. It was paused by the initiative of Jesper Melsen because he has is a member of a group who is developing a European protocol for treatment. So we're going to listen to get some updates about that work. So, but if that didn't proceed to a conclusion and will be a longitudinal affair, maybe we're going to introduce the Nordic protocol. But I have to talk to Jesper and another and see what we end up with. I haven't spoken to him lately. So, but of course we can provide you with what some of the material we have. But when I send a background document, which is actually reflecting the research, a lot of doctors leave their skepticism and are willing to prescribe these drugs and to go on with the treatment principles that I use for my practice and for Røysumtunet.
Yes, but most of it is off-label treatment.
Yes. All we propose are based on research, as I have presented, but it's off-label that it's not acknowledged as a standardized.
No,
but I haven't met any obstacles from the Norwegian health authorities so far because when they ask for things, I provide them with research results and I provide them with my personal experience that most patients experience very well results from this protocol, and I haven't been challenged so far by the health authorities. I know you have a difficult situation in Denmark, but in Norway they have been more, sitting on the fence and waiting. What we say in sitte på gjerdet, say we in Norway.
Yeah. Thank you. Yes, very interesting. So I think this was all the questions. I think that it's important that we also answer people's questions. So no more questions. We can go on to part 2 of your speak, and I'll leave the microphone to you.
Thank you. Yes, I already said that our main problem is actually the financing, but also there are other challenges that we have seen. We have now been running Røysumtunet CFS ME unit for about 3 years, and one of the main questions I have to raise is, what does it do to any human to lay in a bed, isolated, often in darkness, day after day, year after year? I think that nobody can actually imagine how it feels if you haven't been through it yourself. It's beyond imagination. And what these years have learned me is to be humble. I think that when I meet these patient groups, they are very brave. A lot of them refuse to give up, and they're just as different as you and I. And I don't do everything perfect. I try to listen. I try to follow what the patient want themselves, and give them the feeling of steering their own life and their own treatment. And some patients are very passive, that they are beyond any. They don't have any. What do I say? They don't ask for special treatment or special tests that they want us to perform. Other patients are very active, and they search the internet, and they know sometimes more than me about things, and we discuss things, and we try out things, and I try to follow their wishes as far as I can. Not always possible, but we try to be very positive and flexible, and I think that is one of the basic things. If you ask the patients themselves, they would, of course, have certain things against me. We sometimes we have to give up. We have patients where we had said that, sorry, this is beyond what we can do, and some patients were like they're almost dying. We had patients that we had to do resuscitation, and then we have to give up and say these are intensive care patients, and we cannot treat them, because we are actually not an intensive care unit, and we're not staffed for that. So sometimes we have to give up. And the patients and the personnel are very afraid when the patient becomes that ill. And there's a problem that even at Røysumtunet, we don't have unlimited resources. We cannot meet any need. So what to prioritize? We have, even with one-to-one, that's not always enough. So this is a very difficult question. So we don't say we are perfect, and we are learning. We are on our way, but we have gained a lot of experience. And I don't think nobody else in Europe, at least, have our experience with these very severely ill patients, because most of them are hidden. You don't see them. Nobody have done any research on them, because they are in their homes, often with little contact with the official care system. And we are trying to publish some of our experiences in the journal now in a short time, and you can look forward to see what we are summarizing the things that I speak about now, and discussing it in a more proper way. But it's a lot of questions that arise when you try to do something good for these patients. What I can say regarding physical problems, that we are astonished by how few that has bed wounds and contractures. And it is interesting to see one of Anthony Komarov, a professor at Harvard University, who has been researching ME for 25 years. He says that there is a kind of hibernating nucleus in the brain. It has been found in the brain of mice, but not in humans. It's very difficult to find things like that. But it seems that what is happening to ME patients is that they go hibernating, actually, like a bear that go hibernating in the fall and wakes up in the spring. They don't have any wounds or contractures. It's like the body has a steered switch off button, if you understand what I mean. That they So that's very fortunate. But sometimes it happens, but not so very often. But the problem is actually to help them, assist them with basic functions like hygiene and eating. We have to very often we have to feed them. We have one patient where we use he has 4 meals, and to eat each meals we have to feed him with a spoon, and it takes several hours for each meal. So one personnel has to spend most of his days just to give him enough food, just as an example. But we take that time, but very few other healthcare institutions will do that. So somebody are losing weight and some are gaining weight, but all are losing muscular mass, muscular mass, because of inactivities. And we are also very often experiencing that they have too much. They're very sensitive for stimuli, and we have rebuilt all the houses so that they're specially isolated for all kind of noise, and for we can steer very carefully the amount of light, and we try to do everything to not to make the patients even worse. But we are located and in the countryside, and it's usually very quiet. But sometimes a big tractor passes on the road, and that really disturbs them. They can have a bad day just because of 15 seconds of a tractor passing on the road. You understand? And they can hear that through all these thick walls and whatever we have done, and that's difficult actually. So I don't say we are perfect, but we are learning. Social problems. They're losing their social network, and the loved ones around them are very often wear down and completely exhausted from year after year of care for these patients. And very often we take over patients who have a long-standing conflict with the healthcare system because they don't understand it. They tell horrible stories of a nurse coming into the room, opening the window and saying, "No, you need to get up out of the bed. You know, you should have more sound and more light. Come on, get up." I'm not kidding. That even happens in nursing homes where patients has been for a long time, and one nurse come in suddenly and on purpose leave the door open for noise or open the window, or we have a lot of horrible stories actually, not because of they are mean, but out of ignorance, and sometimes we inherit that conflict that people are so critical to all kind of caretakers that they take with them the critical attitude also into Røysumtunet, and we have to use a lot of time to get them to cool down and trust in us and understand that we are different. And yes, that's how it is. And we have been astonished by how many of them who has developed psychological comorbidity. As I told you in the before, how would we react by being isolated in darkness for so many years and lost most of their social contacts, very limited contact even with their loved ones? It's like losing your life. Who wouldn't develop anxiety, depression? And it's also often we see that the little areas in their lives that they can control, then they get kind of OCD about everything has to be exactly like that. You can spend half an hour just to help them to find the right position in their bed. And you have to understand they are not doing that because they want to like manipulate the personnel or anything. It's just because it's painful to them to lie in the bed like that. And you have to understand that this is real. But a lot of them have been exposed to so much ignorance that they have developed skepticism, and they get a kind of rigidity in their personality, and the loved ones around them can tell that they weren't like that in the beginning, but they developed it during the years, and that's not surprising actually. But we have to deal with all these things and find a way of making them trust us, and also sometimes we have to limit what we can. Their expectations to what we can do are actually too high, and we have to deal with that too. So actually, maybe some of you have some question at the moment, because before I speak about the Nordic protocol, I would like to take some questions and comments on what I have been saying so far, because it's quite crucial experiences about this special patient group that have occurred during these 3 years that I know have shared with you quite openly, and I would like you to give some comments, and maybe you have some questions.
I don't see any questions right now in our question box, but as you know, the situation is the same in Denmark as in Norway, and you probably have read Peter Lacour's report on the 19 ill patients he visited.
Yeah.
So
it's a very typical picture, and maybe we have come a little bit further in Norway because we have Røysumtunet, and but the situation is very similar.
Yeah, and we also have Danish patients in Danish nursing homes where they are treated like you just described, a nurse coming in, opening window and speaking loud and let's get up, and all that to a very severe ill patient that has been ill for many years. So they just don't get the question, get the problem, and I don't. We're talking in the association. How can we better inform nursing homes about how to deal with these very severely ill patients when they come in? And will they listen to us? They probably won't. They don't even listen to Jesper Mielsen sometimes. So
no. But we have. I think that the new NICE guidelines have been very useful. We have them as our base for everything we do. We have translated them into Norwegian and also adapted them in a special version for Røysumtunet, but all the personnel are it's compulsory that they have to read that when they start to work with us, and they have to follow experienced nurse or other personnel in the first days they are there, to be sure that they have adapted the right attitude and understanding of what they are doing, so we avoid these kind of horrible experiences for our patients. Because even a few of these experiences can destroy the confidence that the patients have with us as an institution. So we are very aware of that. But I think that it's important that the doctor and everybody who is in contact with these very severe ill patients are introduced to the NICE guidelines. I think they are very useful. So that's my best advice I can give. I think it's the end of what I intended to say. And now I leave the scene for questions.
Thank you, Dag. Just a couple of questions came in during your last talk here. One wants to know if they can get your slides.
Sure.
Mm?
We can send them, but of course, please don't distribute them to the whole world, because we haven't published it. It's not official yet. So we have to trust that it's not going to end in Berlingske Tidende next week or something like that.
No, I think people understand that, and we have your slides. So skriv til os på sekretariatet, og så kan I få tilsendt slides, dem der er interesseret. And the last question is, what is the recommended PEA doses?
Yeah, we use, regarding PEA, it's very important. I got that from Jesper, and he's emphasizing this a lot, that it has to be micronized, because ordinary PEA doesn't pass the blood-brain barrier. It's very important that it can have its anti-inflammatory effect inside the brain. So in order to do that, it has to be micronized. So so you have to check that very carefully when you order these drugs. You can check with Jesper which products are available in Denmark that are micronized. I'm not sure, but in Norway we have something called Norsk Natur Medicinsentral, which is providing a good product. They come in 300 milligram capsules, and we give two capsules, that is 600 milligram, twice daily.
Okay, thank you. So this is the end. Nicoline, are you there?
Yes, I'm here. I'm just gonna round it off. We just want to say a huge thank you to you, Dag, for this very interesting and informative lecture and webinar, and I'm sure that all the members got a lot out of it. And I'm just gonna switch to Danish to promote the next webinar. Så næste webinar, vi har, det er i oktober, den 19. oktober, og det er med Annette Møberg, der er formand for den danske LDN-forening, og hun vil snakke om LDN. Og foredraget foregår også online webinar kl. 11, og I kan tilmelde jer ved at skrive en mail til sekretariatet senest den 17. oktober. Ja. Og hvis I ønsker at få få tilsendt optagelsen af webinaret her, så kan I også skrive til sekretariatet.
Tak til jer, der holdt ud. Vi er klar over, at der var nogen, der ikke kunne, men de kan så få tilsendt optagelsen her efterfølgende. Og især tak til dig, Dag. Fantastisk foredrag. Jeg synes, det var så berigende og så interessant at høre. Vi har mange spændende taler her, men dit topper en af dem. Så tusind tak for din viden, og vi vil meget gerne invitere dig til at komme og tale om den nordiske protokol, så snart at I har noget klar i jeres nordiske gruppe. Vi kan også høre med Jesper Melsen, om der er noget. Der er lige en, der vil spørge om noget. Kan du spørge, Nicoline? Jeg kan ikke lige se, hvem det var.
Jeg har tændt for mikrofonerne, så folk har mulighed for at sige højt.
Var det Susanne, eller hvem var det, der lige stillede et spørgsmål, der stak hånden i vejret?
Det var en fejl. Undskyld.
Okay, fint. Jamen, så er vi ved vejs ende. Tak for nu, og jeg håber, vi ses igen her.
I'd like to say thank you very much for inviting me. It was very interesting, and it's very important that the doctors that treat ME patients have a good relationship to the ME patient associations. So I hope we can continue to have a good relationship, and also for the future.
Thank you. I hope so too. So hopefully see you again, and best of luck with your good work in Røysumtunet.
Thank you.
Bye bye.
Goodbye.